I think CAR T cell therapies are very effective, but bispecifics, are therapies that will change how we manage patients in the community at large.
I guess for patients, it's exciting because it doesn't involve having to probably relocate like the CAR T cells. There's a lot of things happening in multiple myeloma. So let's start talking maybe about the CAR Ts, because CAR Ts have been around for a while. And can we talk about, I think there are 2 approved CAR Ts. Can you talk a little about them and who they're for? And
certainly. So CAR T cell therapies, have been around for a while. As you said, they started early on in another disease called ALL. In children, actually, but the ones that are developed in or have been developed in myeloma are targeting a specific surface protein on the cancer or myeloma cells called BCMA. And there are 2 that are FDA approved for patients who have had 4 or more prior lines of treatment, including a proteasome inhibitor, immunomodulatory drug, as well as anti-CD38 monoclonal antibodies. So really people who have had a lot of prior therapy. And those 2 products are called ide-cel and cilta-cel. And, they both target BCMA, but they are unique products. So, the general side effects, are similar, but tend to happen at different time points. So these are, cell therapy products. So they need to be given at a center that does transplant and cell therapies. So many of our myeloma patients do go for a transplant evaluation and end up getting a stem cell transplant during the early course of their treatment. So the process is kind of similar. Your doctor is going to refer you to a transplant center. They will do the evaluation. And then, get you those commercial products. Typically what happens is, when you're getting a stem cell transplant, you go through a process of getting growth factor shots and then getting the stem cells collected from your bloodstream through a central venous access typically. In CAR T cell therapy, we are collecting T cells from the patient's peripheral blood, but you don't need growth factor shots. So you can get those T cells collected just off of the peripheral bloodstream.
Okay, good. Now, there are some unique side effects to CAR T cell therapy that maybe myeloma patients haven't experienced before. Can we talk a little bit about them?
Certainly. So the way that the process works is, when you get these T cells from the patients, you have to send them off, to the specific, company that's manufacturing them for the manufacturing process. And what happens is, in a layman's way, the patient's T cells are taught to recognize the cancer cell, and they're grown outside, the patient's body, in the lab essentially. So that, production and expansion takes, 3 to 4 weeks. When that product is ready, it's shipped back to the center and patients get a certain, lymphodepleting chemotherapy for 3 days before they get that product infused through the veins. And those T cells are active. They know how to recognize the cancer cells, through the surface marker BCMA, and they're going to expand. So there's an expansion that happens, in the patient's bloodstream, and these cells are growing, and they're trying to go after the myeloma cells. It's like you are introducing, an inflammatory response, in the patient. So the side effects are like the patient's body is going through, an inflammatory process. So the two common side effects are what's called cytokine release syndrome. These immune cells are releasing certain chemicals that help them, enable them to go after the target. And due to that, patients can feel, fevers, hypotension, as if, they were infected with something. So it's that tends to happen with ide-cel within the first 2 days. With cilta-cel, it tends to happen with a delay of 5 to 6 days typically. And we manage those kind of side effects by giving antipyretics, fluids, sometimes, steroids or an antibody called tocilizumab is given to patients. But for the most part, these side effects are grade 1 or 2, so they're kind of low grade and are managed, with those kind of medications.
What about these allocarts? Are they going anywhere? What are they? Can you explain? And they seemed a little exciting.
Yeah, so the idea of alloCAR-Ts is, you can take T cells from a donor, but then knock out certain surface markers to make those T cells, more benign, so that the recipient's immune system is not recognizing them as the enemy, and they're not recognizing the recipient's immune system as the enemy. The advantage of having allo T cells utilized to manufacture CARs is you can have one donor and make a product that can be given to 100 different patients instead of taking the patient's own T cells. And those hundreds of products can be given in a very short duration of time. So essentially, if I see a patient today and I have an allo CAR-T available, that patient can technically get that product 3 or 4 days from now. They can start getting lymphodepleting chemotherapy and they can get that product very quickly. Whereas if I were to see a patient today and try to collect their T cells, even with everything kind of aligning, it might take 5 to 6 weeks for them, from today to get that product. So that's the, major advantage of allo CAR-T products, but they are, they're way behind in terms of clinical development and seeing the light of day.
Okay. We have any efficacy data? Are they working or?
Yeah, they are working. So we have seen some efficacy data. There's an allogene CAR product. In fact, Chmielewski from my program had presented those data last year, showing, about 60% of the patients responding to that allo CAR product. Now, the follow-up is short, so we know that these patients too get CRS and neurologic side effects, but the follow-up was only about 3 or 4 months. So we need longer follow-up to see, is this activity long-lasting or just a short duration activity? And what kind of long-term side effects do we get from using this strategy?
Good. And one more question on CAR T cells before we move on. Right now, the approved ones go after BCMA. Are there any CAR T cell therapies that are looking at different targets on the myeloma cell?
Yeah, so another target is called GPRC5D. Again, that was a homegrown, CAR T at MSK that Dr. Chmielewski had presented, showing good activity in patients who have had prior BCMA CAR Ts and BCMA therapies as well. The response rates, again, in high 60, 70% range. Looking at, the various cell doses that the patients received. And that CAR T is now, being developed, by BMS. So there are other programs that are utilizing that CAR T. We also have some very interesting, dual CAR T, BCMA and CD19 CAR T data that was presented by colleagues from China at the ASCO and EHA meeting, showing high response rates.
Can we talk a little about teclistamab? I think it's already approved in Europe, isn't it? Or
I've been involved with teclistamab from the very beginning. In fact, the first patient who was ever treated in the world was my patient. So I've been with that program from cohort 1, patient 1. I think CAR T cell therapies are very effective, but bispecifics, are therapies that will change how we manage patients in the community at large. And they actually might challenge, CAR T cell therapies because, they're an off-the-shelf option, giving, high response rates of, again, 60-70% in relapsed refractory myelomas, very similar patient population to CAR T cell therapies, and it's given subcutaneously. Now, cytokine release syndrome is something that we see with the bispecific antibodies as well, and that's something that we have to watch out for. The concept of this technology is very interesting. So, you're going to hear TCE or T-cell engager as a terminology. You're going to hear bispecific antibody as a terminology. The concept is the same. One part of that molecule recognizes the surface marker on myeloma cells. It could be anything. It could be BCMA, it could be GPRC5D or something else. And the other part of that molecule recognizes the T cell. So, there is, surface marker CD3 that it recognizes. So, so the difference between T cell engager and bispecific antibody is the structure of that molecule. If it's a whole antibody, then you call it a bispecific antibody. If it's only a fragment of an antibody, you call it a T cell engager. And different companies and platforms have different molecule structures that are proprietary. So the names are going to be different. So long explanation, but a lot of excitement about that technology. Teclistamab is the front runner. We might hear some good news about it later this year in the US and Europe. And we're all really excited about that platform.
Yeah. I guess for patients, it's exciting because it doesn't involve having to probably relocate like the CAR T cells. You have to go to a CAR T center and spend time away, maybe from your home and family. Would the bispecifics be something that could be given maybe at a community hospital, or is this something that you need to go away for too?
Like, getting any subcutaneous treatment. So, the short answer is yes, it will be possible for patients to receive this treatment out in the community, but I don't see this happening during the first year of the FDA approval. It will be, a steep learning curve for our community docs.
Okay, and what about the efficacy? How does it compare to CAR Ts?
So response rates are around 63-64%, which is very high, and the median duration of response is, or I should say median PFS is about a year, so almost 12 months.
That's exciting. There are other bispecifics beside teclistamab. There's the telquatamab. Is that how you say it?
Telquitamab.
That's good to hear. And there's many others, right? There's not just these two. There's a lot of bispecifics out there. Are they all doing quite as well?
Yeah, so, for BCMA-directed bispecifics, there are several options. So elranatamab, is very active. ABBV, 838 is very active. There's a Regeneron bispecific. There's a PMS Celgene T-cell engager that's targeting BCMA as well. All of them are showing very similar kind of activity.
And as a patient, that makes me feel good. Even though some people say, well, you might be able to use another BCMA-directed therapy. For me, I would like to have another target in my back pocket. So keep developing those targets there. There were these TRIMM trials, TRIMM, TRIMM trials. So now they're not only using the bispecifics, but they're combining them with things. Can you talk a little bit about those TRIMM trials?
Yeah, so once the efficacy and recommended phase 2 dose of both teclistamab and telquitamab were ascertained, the next step was, can we combine them with other myeloma treatments and see if, we get, better clinical activity. So the TRIMM-2 study is looking at the subcutaneous daratumumab administered with, telquitamab as well as with teclistamab. And there is combination study of adding pomalidomide, to those combinations as well. The overall response rate with each of those combinations is about 80 odd percent. Which is remarkable. These, because most of these patients were daratumumab refractory in a previous line of treatment. So very encouraging. What does this mean? It means that, we can potentially, use this combination in earlier lines of treatment, even for newly diagnosed patients. It would be really cool to have a non-chemotherapy approach just using antibodies.
When you talked about transplant-ineligible patients, there's that group of patients that really are not eligible for transplant for whatever reason. Would those group of patients not be eligible for CAR T-cell therapy, or would they be possibly eligible? I know you have to look at them individually, but as a group, is it just like you're not eligible for this or you're not eligible for that, or can you?
So I think we are a little bit more lenient in CAR T-cell therapy eligibility compared with stem cell transplantation because patients are not getting the same level of myelosuppression with the high dose chemotherapy like a stem cell transplant. So there might be patients who are in their mid 70s or even late 70s who are able to get CAR T-cell therapy that we would not necessarily pick for a transplantation. So I think that there are we're thinking about CAR T-cell therapy in a more lenient way because of the safety profile.
That's good to hear. So, wow, we talked about a lot today, and it's just amazing, all these new therapies. I know when I was diagnosed back in 2008, I think most of the things we talked about weren't FDA approved except Revlimid and Velcade. All the rest have been around. So when you see a newly diagnosed patient or even an older patient who may be relapsed refractory, how do you provide them with hope with all these new treatments? What are your words of wisdom to these patients?
I give them the context. I tell them exactly what you said, Cindy, and I tell them about the time when I was starting in the field in the early 2000s and how the outcomes were for myeloma patients, and I walk them through how things have improved, what our goals and expectations are today for our patients and the treatment options we have. So I provide them with measured hope. And even for patients who have high risk myeloma, we're thinking about things in a different way and trying to be proactive in giving different strategies for those patients rather than just treating them in a vanilla, one size fit all kind of a way. So I provide, that context to patients, and then, it's really about individualizing treatments based on patient preference as well. This is really a partnership. Our job is to provide patients with as much information as they can, gather to make good informed decisions.
Good. And one last question. Now you probably have to get that crystal ball out. You did mention the word cure. Do you think we'll be curing any myeloma patients anytime in the future? And what do you think that would look like?
So I would say yes. I think, this is something that I've shared, on other forums as well. I do feel that if we can, get patients to undetectable levels of myeloma over time. So, there's this, term called MRD or minimal residual disease negativity. If we're able to get patients to MRD negativity and maintain them in that MRD negativity for a certain period of time, and then stop therapy at that time, then we can, functionally cure, majority of patients. Myeloma is a disease that tends to occur later in life. There are other competing health issues that patients have. So a true cure, cannot be determined when, in that kind of a situation compared to someone who says, someone who was 20 and they got diagnosed with a cancer and they die of a heart attack at 90. You can say, okay, this person was cured from a cancer. You can't say that about, myeloma patient who's getting diagnosed in their 6 or 7 decade of life. But, if you can, kick myeloma down to undetectable levels, stop treatment, and patients, continue to thrive for years, and the cancer doesn't come back, that's in my mind functional cure. Yes, my answer is yes, we're going to get our patients there. The key would be finding the right recipe to get patients to that sustained MRD negativity before stopping.
Right. And now we have so many ingredients for that recipe that I'm sure we're going to find it soon, I'm thinking. Thank you so much. It was a pleasure talking with you this morning, and hopefully I'll get to see you soon.